Hi, my name is Debbie, and I am obsessed with all things to do with ultrasound. I'm an empty nester who has spent the last 28 years scanning in all different kinds of situations: clinics, hospitals, point of service, emergency departments, private offices, echovascular, general, high risk OB, and want to dive down deep into all things to do with technology, techniques, and transformation. It's time we take ultrasound to the next level. Think of this like your little power boost on your commute to all things ultrasound, along your way to the thing that we call work. So pull up a seat, make sure you're comfy, and be ready to be challenged and encouraged as we learn it's all about the frequency. Today, our guest is Brandie Bach. She is currently the Sonographer Program Director at Tarrant County College in Fort Worth, Texas. Brandie began her career as a radiology technologist after graduating from TCC in 1990. She continued her education at Dallas County College, where she studied sonography. She went on to complete her Bachelor of Science in Healthcare Administration and her Master's of Science in Instructional Design and Educational Technology. In her 34 years as a sonographer, she has worked in various hospital and clinical settings. She also worked in commercial ultrasound. She has spent the past 17 years in sonography education. Brandie enjoys volunteering for several different international organizations that promote sonography education. She has been fortunate to work on 7 different international medical mission trips. Please help me welcome Brandie Bach. Brandie is an educator and teaches many students who are coming up through the ranks. And she has offered to share her experience and strength and hope for effective strategies for improving teaching in the clinical setting. And I'm super excited about this topic because I personally have had a lot of different kinds of training in the 30 years I've been scanning, and have definitely come away with some good tips, and yet some tips that I'm like, yeah, maybe I could have done that a little bit different,
Yeah, definitely.
So welcome, Brandie, and thank you for coming on.
Oh, thank you for having me. So my name's Brandi. I've been doing ultrasound since 1993. I've done OB, general, vascular. I went from the clinical setting to an MFM setting, and then I left MFM and went into commercial ultrasound and did applications for 7 years. And then I left commercial education for traditional education. So I've been either a clinical coordinator or a program director for 16 years now for KHEP accredited programs.
Awesome. And
Yeah,
what area are you in?
I live in Dallas, Fort Worth.
Oh, perfect. Awesome.
Yeah, and we have a lot of ultrasound schools in our area, so there's a lot of competition for my students here.
Ah, good.
Yeah,
That's interesting because a lot of bigger cities don't have very many options. So
we have too
that's kind
many.
of good that you do. You have too many?
Well,
Yeah,
just because we all fight for the same clinical sites,
right.
that's the challenge of having that many programs, but it's good for the students.
Good. Good.
Yeah.
So tell us a little bit about yourself. Why did you get into ultrasound? Why have you stayed? And why did you choose education in the end?
Well, I got into ultrasound because I first went into X-ray school, and in X-ray school, I realized I don't want to do X-ray school. So
Right.
we got to rotate through the different specialties. And my best friend in class, she said, I think I'm going to do ultrasound. And I'm like, I think I'm going to do radiation therapy. That just sounds so much smarter. And so I did a month in radiation therapy and she did a month in ultrasound and we hated it. And so she's now a radiation therapist and I went into sonography. So, and I've loved
Awesome.
it ever since. So I went
Awesome.
straight from x-ray school to sono school, but I worked along the way as an x-ray and CT tech until I got through sono school. But yeah, so I've
Yeah.
been doing sono all these years and I love it. And what I like about it is when you get bored with something like outpatient or inpatient or clinical, there's so many different avenues. You can go into commercial ultrasound like applications, or you can go into management, or you can go into traditional higher education like a sonography program. So, And I do a lot of international medical mission trips. So that flexibility with the school schedule gives me the opportunity to travel abroad and do training there because I really enjoy international education. That's my heart.
Yeah. Yeah, I think haven't you and I had that conversation before about international, and so make sure you check that podcast out too. So um let's talk about there's a lot of different strategies that you can use when training, and a lot of sometimes different moving parts, right? To
Definitely.
training someone. And so let's just talk about the purpose of why should we have a strategy when we're trying to train someone?
Well, I think the downside to having students at clinical sites for a lot of technologists, whether it's X-ray or sonography, they're not trained to educate. I mean, I wasn't until I got my master's degree. My associate and undergrad aren't in education; they're in imaging and
Right.
healthcare administration. So I didn't really learn how to teach effectively till I got my master's. And so a lot of these people at clinical sites, they're like, "Oh, here's a student. Have them for 8 hours," and you're like, "What do I do with a student? How do I teach a student?" And it's just because they weren't given the proper toolbox. They're great at their job. They're great at being a sonographer or staff technologist, but they don't know what benchmarks. The students just say, "Hey, I need these 5 pictures today." And they're like, "Okay," you know?
Yeah.
So I usually, I created a bunch of micro lessons for a lot of clinical sites, like 5 things to work with them today. Like I usually tell them, ask the student, what are your goals today? Tell me what your goal is. Do you want to work on, if it's ultrasound, do you want to work on getting the gallbladder today? Do you want to work on a venous today? What is your goal today? And so if they kind of set that benchmark, then they don't think I've overset my expectations for them. And then what do you need from me to get that? So and there's a couple different teaching strategies that they can learn. They can look up Bloom's taxonomy. That's like different hierarchy levels of learning. And so with like a first year student, I usually do like the first 3 levels. It's kind of basic recall facts like, tell me a protocol for a gallbladder, or tell me what labs are associated if the patient has cholecystitis. And then I get into higher order thinking with like a second year. Okay, this patient has acute pancreatitis. What does that look like? How does that look different than chronic pancreatitis? What are some causes of chronic pain? So I make them start thinking through more critical thinking, and what other modality would they order that would complement this study? Would it be a CT? Would it be an MR? So that's kind of Bloom's taxonomy, where we kind of try to figure out where they're at and then meet the questions to where they're at. And then there's some other learning strategies like scaffold learning, kind of like, when you learned how to ride a bike, somebody just didn't throw a 10 speed at you and you figured it out that day. They kind of showed you how to ride a bike, then maybe they gave you some training wheels and walked behind you. And eventually they kind of pulled back. And so that's what they kind of need to do. Show them how to do a gallbladder exam, let them shadow it, let them pre-scan or back scan. Maybe you get the right upper quadrant, and then I'll get the kidneys and the rest of the pictures, and then kind of scale back. So, but these are toolboxes that a lot of technologists and sonographers don't have. We just get told,
Right.
well, here's a student, figure it out, and then
Right.
the student gives you an evaluation. You're like, okay, I don't know how to evaluate you.
Right.
So,
And I want to go back to a couple things that you've said, right? Because you kind of blew through a few things, like you're breaking it down, right, for the student or for the person that you're training on the new job, right? So, first of all, here's what's required, right? This is what we're needing you to accomplish.
mhm,
And then, okay, let's just break it down. Um, let's just start, if I'm in high risk OB as I am, let's just do measurements. Let's do that for a day, see how you are, maybe half a day, depending on what your experience level is.
mhm.
Let's just do that, see how you are, and then we'll build on that, right? So I like how you said that. Well, this is the first level, and so this is what we're going to do. We're going to just do this part, and then I'm going to do the other parts, right? So I love how you set the expectation. Then you mentioned that you let the student own the goal, right?
Yeah. Tell me what you need today.
And so then they feel a part of their process, right?
Mhm.
So I think that was an important point that you made as well. And then you didn't give them the whole exam at one time. You just like, okay, let's just try this first. And then
Well,
until
and
they prove their competency with it.
And the OB example you gave was perfect because today, for example, at school on Wednesdays, we do OB. So I teach OB class in the morning and then I have an OB lab in the afternoon. And so today was all the head images, BPD, head circumference, cerebellum, cisterna magna, lateral ventricles, all the things. And so once you get that, then we're going to move on to the next thing. But a couple of them have already moved on and, now working on nose and lips and coronal and palate pictures. A couple of them are still stuck at the cerebellum level. So it's like, okay, we've switched patients. So it's not the baby. It's what's missing. What are you not getting? Is it the positioning? Is it the relationship anatomy, the spatial awareness of where tell me what you need. And then if they don't get it, then I make them go back and show me on the phantom. Show me how to get this on the phantom. Okay, now let's go back to the patient. Just keep going back until we can move on to the next level. Yeah. But I do try to get them to clarify, what do you need? Is it positioning? Is it the equipment? Is it rotating the transducer? Where do you feel that you need the most help? Most of the time they know.
Those are good questions, right? Let's talk about a little bit about the different perspectives, right? The student perspective versus the instructor or the mentor's perspective. Tell me a little bit about that.
Well, I see that that's changed. I mean, just from the time that I started teaching ultrasound, in 2010 for school versus now, we're in 2026. The landscape of the clinical settings changed and the landscape of students have changed. So clinical settings, all the sonographers are burned out. It doesn't matter your specialty, if you're outpatient or MFM or cardiac, you're overwhelmed. They keep giving more and more patients with less time and less resources. So sonographers are burned out, clinicians are burned out, but the students are a little bit more entitled. So it's a balancing act. I have the clinical sites that'll tell me, well, this student did XYZ. And then I have the student that comes and says, well, this sonographer said this and that and the other. And it's like, the truth is somewhere in the middle, and I have to keep both of you on track. So that's why if I can get the clinical site to set up the expectations and help the student, that usually eliminates some of that miscommunication barrier.
Right.
But I do have, I have a clinical instructor who's a great sonographer. She just is not good with students. She's actually told my students, if I don't make you cry at least once a month, I'm not doing my job. That's a bad attitude.
Wow. Yeah.
No, I mean, we've all had an instructor or a technologist that we've worked with that scared us and intimidated us, but your goal is not to do that on purpose.
Right. Right.
So,
yeah. And I think that's where a big mind shift has happened through the generations, right? Like in our era of growing up, we had to shut up and put up, right? And now this generation is like, I'm not putting up.
They're much more sensitive.
Yeah. And there's a lot to be said for that, right? Like, you're right. You shouldn't put up with that. And I think in healthcare specifically, we have put up with a lot, and it has made it super toxic at a lot of places. So I think the newer generation, the younger generation has been good for us in that realm of, I'm not going to do that. Right. Yeah. I'm not going to put up with that.
Right. But there is the flip side of that. Like I just had a conversation today because my students, like I mentioned, we have a lot of programs in my area. So my students compete against other students at clinical sites. And I hear from the clinical sites, oh, I'm glad that your students aren't acting like this student because, they're just on their phone all the time. I mean, that's a huge no-no. You are not on your phone for any reason at clinical. If you are, you need to step outside of the patient area and handle that and then come back. If there's any downtime, you still need to stock those towels and fill those gel bottles and clean those machines, just like we did in the 90s. That's still your job.
Right.
Clean and
that hasn't changed. Some of that hasn't changed. Yeah.
Yeah, because
I think the respect issue has, right? I think
definitely. But like I've told the students, when you graduate, they're not going to remember who got the best cerebellum that day. Right. They're going to remember the person that jumped up. Let me help you with that, even if that wasn't your patient. Let me clean your room and stock it and turn it over real quick. They remember those things. That's what's going to make you a good sonographer and want them to hire you, is how well you were helpful.
Yeah.
So that's kind of part of the landscape. But yeah, setting up those expectations for students and not having the sonographers that want to intimidate them. And that's not all of them, but there's always, one that's going to
Right.
be a meal. So
Right. And I have done some research and some training myself, or mostly research myself. And I think when someone hires you, what they're wanting is humility and competency, right? So, can you be humble enough to clean the sheets, fold the towels, fill the gel bottles, take constructive criticism, right?
100%.
Even if you don't agree with it, right? And then can you become competent? Can you eventually take that and become competent in what we're doing? And those are the kinds of people that they want to hire, right? Is you have humility enough to say, yep, I can do different or better.
Mhm.
But I can be competent as well. So I think as a beginner, I think those two things are kind of important to kind of focus on, right?
Definitely. Well,
Student.
and I think hiring managers, and you've been a sonographer long enough, would I rather hire somebody that knows how to get every picture beautiful the first time, or somebody that's a pleasure to work with and I enjoy going to work every day?
Right.
I'd rather have a person that I can have a good conversation, we have good teamwork, we can collaborate. I can teach you to get a good cerebellum picture.
Right.
I can't teach you to have, good patient care and good empathy skills for our patients.
Right.
So that's part of it. And, and students, that's the other part, like you mentioned, is constructive criticism. I don't know that it's so much this generation, and I don't mean to disparage this generation. I have children that are in this generation. My children are almost 30, but they don't accept constructive criticism like we did. And part of that's good. They're more self-aware and they stand up for themselves better. But then part of that is everybody gets constructive criticism, that it's just part of life.
Well, do me a favor and define constructive criticism.
So, nobody likes to hear, usually like when I'm giving a student constructive criticism, I try to mention one thing you did really good, one thing you've really improved on, one thing we need to work on, and then another, it's kind of a sandwich, positive, negative, positive. And so,
Oreo.
little Oreo. And we all need that. We all need to be reminded, you need to work on this, but you did this so good, so good. I want you to even show this person how to do it because you did it so good.
Right.
So, when students, and it's you might already be having a bad day. Maybe something's going on in your home life. And that one comment from that sonographer just really took you down that day.
Yeah.
And my students come to class and I'm like, don't complain at clinical. Don't complain at clinical. You come here. This is like family therapy.
Right.
Vent to your classmates, vent to me and my other instructor, and we'll listen to it. Like I'm like your room mother, you can tell me anything. But I tell them it takes rain and sunshine to make the flower grow. Today you got rain. You got a lot of rain.
Yeah.
But that you're going to grow from that. Sometimes the sun's going to be out tomorrow and you're going to be a bigger flower tomorrow. It's just
Right.
part of it,
And I
and
like this quote that you put in that says sometimes students are not disengaged, they're overwhelmed. So
definitely.
talk about that because I think anytime someone starts a new job, it's overwhelming. And if something else is going on in life, if they're relocating or if they're moving or if they're getting married or if they're having a baby or that just kind of piles on, right? So
Yeah.
I think it's important to recognize where the person is coming from,
And
right?
like you said, and I think with this era where we're at now, I think we try to be more mindful of people's mental health, and realize that everybody has a life outside of this office or this clinic. You have a marriage or children or a job, or maybe your car broke down on the way to work, or, maybe you're going through a divorce and you're trying to figure that out.
Right.
Everybody's got something. So I think we're trying to be a little bit more kind in general to our students and to each other. But yes, I have students that pretty much are homeless and couch surfing, as single mothers or, you know, everything. I've seen them. So,
Right.
and sonographers too, they'll, so and so was so mean to me at clinic yesterday. Well, maybe she's going through something. I mean,
Yeah.
I'm not saying that's a kind way to be, but give her a little grace. Maybe she has something.
Give her a
Yeah.
little grace. And what it doesn't mean that you're lowering your standard of what you're wanting from that person. It just means, hey, look, I'm going to maybe not be so hard on them or not give them a ton of, things to work on or whatever today. Maybe I'll just give them 3 things instead of 5 things. So I think kindness goes a long way, you know? And when you can offer grace to somebody and kindness, I think you get it back in return, right? I think we've talked about that.
Yes, and I make my students watch an empathy video every year. And I cry I've watched the same video every year for 16 years, and I cry every year. It's a 7-minute video on patient empathy. But it starts, and there's no words in it. It's just patients moving through the hospital with little bubbles above their head, like found out it was benign, found out it was malignant, found out they're going to be a father, just
Right.
put their husband on, signed a DNR for their husband. And it is just it, and it says if you could read their mind, and
Right.
you're on the, and I'm mindful of that. And don't get me wrong, I have days too, but I got on the elevator the other day with somebody that was such just a jerk on the elevator. I didn't even know you could be that angry on an elevator. And I was thinking back to that video in my head, maybe he just got bad news. Maybe he just had to sign a DNR for something, and maybe he is just a jerk. I don't know. But I try to recall those things in my mind because maybe he is the guy that, and I'm in a hospital parking lot. Maybe he did get bad news or something bad happened today. I don't know.
Yeah.
But I try to be more mindful and remind the students. Anyway, that video makes me cry every year.
I think I've
Whoever
seen
put it together did a really good job.
right. I think it's an excellent way to show empathy and understanding about things that you don't know and you might not ever know, right? Like
Well,
there's some
definitely.
things I'm not going to share with people at work, right?
No, and I don't usually talk about my personal life at work. I mean, that's just, I mean, they know I have a family, but I don't go into details and stuff.
Right, right,
Um, and last year, one of my best friends got diagnosed with 2 forms of cancer, and she had asked me. She's like, and she's a X-ray technologist. She's like, hey, can you? They asked me to have family and friends in when the oncologist comes to talk because they said often family that you're so overwhelmed with the details, I might not catch all of what he's saying
right.
because I'll be emotional. So I want you in there with me. And her family was in there, but they're not medical. And so she's like, I want you in there. And as soon as he started talking, oh my God, I forgot that I was ever in healthcare and just started bawling like a 2-year-old.
Right,
And I'm just like, oh my God, what is wrong with me? I'm trying to remember all this stuff that she told me to look up, and all
right,
these facts and statistics. I had, gone on Chat GPT last night, and that went out the window when he's talking about different options and lifespans. And I'm like, oh my God, I've never been on this side of
right,
having somebody get news. I've been,
right,
a radiologist or a pathologist tells a patient, but not somebody I cared about.
right.
So, and I was telling the students, I said, it humbled me to feel like, it wasn't my diagnosis, but it was very humbling to be on that overwhelmed with healthcare information. And, so, and I told them that whole week, I'm not really in a good headspace this week. So please don't ask me anything complicated because I got a lot going on in my brain. You know, Sometimes you just have to tell people that.
Yeah, yeah. Which is again setting expectations, right? So, which goes into the perspective of the instructor, right? And you just demonstrated that, right? I'm not on my A game this week, guys. So, you know,
No, and
don't,
I think if you're honest with them, there are some instructors I work with, and they're worried when a student asks them something if they don't know that they might look, like they're not up to speed or that they're, not. And I'm like, we can't know everything. And even if you do, technology changes, elastography, contrast, those are all MSK. That didn't exist when I went to ultrasound
right,
school. And
right.
ultrasound and our technology is so evolving that you're never going to know it all. So I never think that, I tell the students, you know what, I'm gonna have to look. That is a great question. It's such a good question. I got to look it up.
Yeah.
Good for you.
Which is humility, right? I think as a instructor, some of the perspective is being humble because some of the things I've learned recently are from new grads right out of school, you know? And I think, you know, everybody has something to offer. So I
Well,
think
they
it's
teach me all the time. I went to comp a gallbladder a couple of years ago, and I started to take points off because she measured the gallbladder in transverse, the wall thickness. And I said, no, no. Or she measured it in AP. And I said, no, no, we measure it in transverse. And she said, no, no, we measure it in sagittal. And I said, no, we don't. And she's like, yeah, I had to look it up. They changed it. You measure the gallbladder wall in a sagittal plane, not in a transverse. And that has changed. So, you know, you're never going to know it all.
right.
And
You're
that's
not.
okay.
So that's okay, right? So knowing your limitations and maybe your limitations are for the day and maybe your limitations is, oh, maybe I need to look that up again, you know?
Well,
Um,
and I remind the students of that. I mean, in 20 years from now, you may have a student that asks you a question and you're going to have to take a step back. And I don't know if Google's going to exist in 20 years or Chat GPT, but you're going to have to look it up
right.
because either you forgot because you've put 100 more things in your brain since then, or the technology and the what we do is different, the protocols.
Yes.
So,
The thing I
be
think is an important part of the perspective of the instructor is I think what we have to understand is that we're all building relationships.
100%.
So I kind of want to get to know the person I'm training. Are you single? Are you married? Do you have kids? Do you have dogs or cats? Or, do you have to travel a long distance to get here? You know, what are maybe some obstacles for them, right? Uh,
Mhm.
just so I can have a better understanding of them. I'm wanting to be able to serve them as best that I can. And so I want to know about them and their experience. If they've been scanning 50 years, I want to know, how they're doing and how they, were some of their tricks of the trade and different things like that. So I
And
think to remain humble, but also to remember that ultrasound's a small world and you need to have good relationships. And I think you need to have a good relationship with the people that you're working with. The other day, I saw a clip of a coach in March Madness,
Mhm.
and she got in her one of her players' face and
Oh,
was reminding her of how good she was and how she was built for this moment and how she was up for the challenge. And, everybody could see this. They were reading her lips. The announcer was really, talking it through. And she said in a interview after the game, she goes, you have to have a relationship with your players. And if I didn't have a relationship, I couldn't have pushed her like that. I couldn't have told her it's her turn to stand, or it's her time to stand up and take the lead and turn this game around, right? And so I thought, wow, what an important lesson. Like you do need to know your limits of your, you know, person that
yeah.
you're working with, but also their strengths of when you can let them go, when you can trust them to be thorough and consistent and do a good job. So I think that being aware of needing to build a relationship is vital.
Yeah, and and you have just like coworkers, I have students that volunteer their whole life to me, their whole family tree. And then I have some that I barely they barely tell me anything. So how I usually kind of get around that or, encourage them is what is the hardest thing about ultrasound for you? Or, what if we're working on OB, what is the one image you hate? What is the one image you hate? Why? Do you hate it because you have trouble seeing the fetal kidneys because they blend in sometimes? Is it, the LVOT because you can't get your hand just right? What is it? And then they kind of open up into why they don't like it. So I kind of approach it that way. But sometimes they'll just tell me, I just don't like that exam. and I don't know why. Okay, that's fine.
Yeah,
But if there's something that I can do to make that exam better for you, then let's work on that,
right,
or that hospital or that protocol or whatever we're doing.
right,
There's always going to be something you don't like about your job. And we all have that. I can't fix
right,
everything, but I
right,
can I can try.
right. So talk to me about the role of a mentor or preceptor or trainer.
So that's really good. So those are terms that get interchanged a lot and they really shouldn't. So a mentor is usually somebody that's like at the hospital that they've said, okay, you're like if you're a new hire, okay, stick with Debbie. She's going to mentor you this week. She's going to kind of show you the protocols, show you how the OR wants this and how this doctor wants these biopsy trays set up. So that's kind of the mentor. Preceptor is usually employed by the school. Like when I go to clinical sites or my adjuncts go to clinical sites to visit the students, I'm being paid by the school. So I'm not an employee of the hospital. So I'm a preceptor. So I have the time to dedicate to see that student. I don't have a patient load like the sonographers do. So I'm there just to see that student and to comp them or ask them questions. Or if it's slow, I'll have them scan me or something. I have an activity planned. Whereas a mentor at the hospital, if they've just been stuck with a student, here you've got a student 3 days a week, they also have a caseload and outpatients and inpatients and ERs, and they might not have time to work out micro lessons for the student and help them with their comps, but I do. So that's my job.
Right.
And sometimes the mentors, they're great, but sometimes they just don't have the time to afford to teach a student because they're just trying to get through their caseload that day.
Right.
And I do try to remind the students, and most of them catch on. There's days where it's slow. That's great. They might let you scan every single patient that walks in. They might even lay down and let you scan them. Then there's going to be days that they are running and the gel bottles are empty and the towels are empty, and you're not probably going to touch the probe that day. And that's normal too. But you're going to learn,
Right.
you know, you'll learn how to multitask. You'll learn something every day, whether you scan or not.
Right. Right. But I think the primary purpose of the person in clinical teaching,
Mhm.
either mentoring or being a even though their roles are different,
Mhm.
or someone training, I think the general purpose is to guide, to encourage, and then to model what you're wanting them to do, right?
Yeah.
I
Yeah.
think those
So
are some key skills for people who are training, mentoring, or being a preceptor, either one.
right. And hopefully their hospital, if it's a bigger hospital, usually they kind of have a train the trainer. Like if it's a huge like university hospital, maybe they'll have their lead tech or whoever is working with students the most, they'll come and I'll kind of give them a workbook on some tips and tools, little toolbox for them to help them with students. And so maybe that person always has students, but if it's a smaller hospital, they're doing everything. They're going to the OR, they're doing the ER, and they're having to take a student. So they might not have the time to learn all those little things. So I just try to give them helpful hints when I'm there. And if they're slow, then I try to role model like questions to ask. If they're a new student, just ask basic recall facts like a lab question or a protocol question or an anatomy question. They should know those. But then in their second year, let's start to get recall questions like, critical thinking. What would that look like on a CT? What is a hypoechoic lesion versus, a solid lesion mean, for the patient's, prognosis? I mean, different things like that. You know, what does a D dimer indicate? What does a D dimer not indicate? Things like that.
Right.
So they learn by observing me, ask them questions, and sometimes they're like, "Oh my God, your teachers ask a lot of questions." And I tell the students, when I ask you questions, I'm not grading you 100% on every question I'm asking you. I might ask you 10 questions, and if you know half of them, we're good. But if you don't know any of them, then I got to start at the beginning. Like, why don't you know this?
Right.
Where did I lose you?
Yeah, and I think it's different when you're a clinical instructor, right? You want to kind of be prepared. I think if you're a clinical instructor, there's more paperwork. I think there's more documentation. There's more required of you than your routine 9 to 5, right? So I think that is something to be considered before you sign up and raise your hand to say, hey, I'll be a clinical instructor, thinking it's all going to be fun and cherries, right? There is a commitment to it, which may require some work on your own at home, as well as extra documentation, right? For
Right. And sometimes if it's a newer clinical instructor, if they haven't had students very long, I have one that last semester she had a problem with a student and she wasn't sure if it was her or the student because she's new at teaching. So am I not doing a good job teaching or is she not doing a good job studying? She was kind of lost there. So, I had to do a couple of interventions or another instructor just to visit and see, who, and it was kind of in the middle.
right.
Yeah. They were both kind of lost on where their roles were, and it's not hard to get people back on track.
Yeah. 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 No one's perfect, right?
We're all learning.
But I do want to say too, you say here, students learn from what we say, but also from how we act. And my line has been, people will do what you do, not what you say.
Exactly. How many times have you been training somebody and you're like, okay, this is not how you're not supposed to do it, but this is how
Right.
we do it, you know?
Right. Right. So, your routine of preparing for the patient, your routine for preparing the room, your routine for coming out of the room and reviewing your images, your routine for how you present to the doctor, all those things, they're habits that ultrasound techs have developed for their own success. And so I think those are noted, right? Those are noted by the student. Do you show up 5 minutes late, or do you slide in 3 minutes before, or,
Well, yeah, absolutely. And, we have our students, they have to present every semester to a radiologist. They have to do 5 exams with the radiologist read. And they don't, and if they have to read with the radiologist 5 exams. And if it's not ultrasound, that's fine. They can sit and watch and read a CT. But I want you to interact with the radiologist and see how they word things, what they're looking for. And I also ask them questions like, okay, I'm a difficult patient. I don't understand this exam. Explain this exam to me. Explain what you're looking for. Because, patients ask 100 questions. And
right,
what's we all have our own little spiel that we have. What is your spiel going to be? What are you going to say to the patient? Because they're going to have questions. They're concerned.
right, right.
So I kind of walk them through role playing, like I'm difficult to explain this procedure to me. Why do I need this thyroid biopsy?
Yeah,
So those are all role playing things that you can do when you don't even have, like while I'm setting up a room, I ask the patient those kinds of questions, or while I'm waiting for a radiologist to come in, okay, what's the radiologist going to ask the patient? What are some key things that we have to talk to him about, an informed consent, things like that. You can do that in 5 minutes.
right, right. I think that's good.
And that's all role playing, like you said. That's all role modeling, not role playing, role modeling.
Yeah. Which is a huge way to teach, right? As long as the student is prepared to take it all in, right? Which most are, I think,
Yeah. And, it's just like if you've ever had a toddler, I dropped a stick of butter one time and I said an expletive, and my toddler called butter that expletive for like the next 6 months.
Yeah.
It didn't matter how many times I said it's called butter. He saw that one time and he got a laugh out of it. So that was funny. So
Right.
students are the same way. You might have a bad interaction with the patient, and that's what they're going to remember
Right.
was you lost your temper with a patient who was in pain and cranky with you.
Right.
So.
Right. Right. So how do you improve teaching without adding time?
So you can do kind of like little micro lessons. You can talk to the students while you're setting up the room, ask them critical thinking questions like, okay, we've got a gallbladder coming in. What labs should I look at? What symptoms go with that? What is clinically correlated? What's a twinkle sign? What is an acoustic shadow? What proves it's a gallstone versus a versus sludge, or a polyp. So I can ask them those questions while I'm setting up the room, or while I'm walking to the ER to go get the patient. So you can just ask them questions like that. It doesn't always have to be scanning, or if you're doing OB, okay, well, this patient is at risk for trisomy. So which trisomy is Edwards? What key markers go with Edwards syndrome? Things like that. They can walk through those while you're not even in front of a machine.
Right.
So those are things you can ask them.
Yeah.
So those are kind of little questions that I kind of have like a little template with its OB or vascular, whatever, just some little questions like lab questions. When I visit students, if they're showing me an exam, like say a venous Doppler, I ask them a protocol question, whatever the exam. I ask you a protocol question, a lab question that goes with it, an anatomy question. I usually ask them some type of, if it's Doppler, some type of abnormality or pathology question. And then I'll ask you another modality. So if they have a complete occlusion, what other modality are they going to do before they do a bypass graft? Are they going to do a CTA? Are they, or if they have a PE, what other imaging modality will show a PE besides a CTA? Oh, okay, a lung scan, a nuke med, so things like that. So they need to know. And also, if it's a slow day, the technologist shouldn't be afraid to tell them, hey, you know what? Let me walk you over to CT. Let's see if they've got some, time to let you watch 3 or 4 CTs, or if you're doing breast, like maybe you can watch a breast ultrasound. Those are things the students like that. They like a change of pace. They like to just kind of clear their mind and learn something new. Even if it's nuclear medicine, they're never going to do it, but at least they'll have a better understanding when the
Right.
patient says, my next exam's a nuclear medicine exam. Do you know what that is? Well, yeah, I kind of do,
Yeah.
so it helps. And now on our registries, we have CT and nuclear medicine and MRI questions on our registry, which is
Wow.
crazy. So
Yeah.
the more they know, the better they'll be prepared.
Right.
So.
I think that's awesome. I love that you're asking the students questions. I think as an instructor, sometimes we can get into the habit of talking at people instead of to people. And so I think asking them questions is a huge way to build that relationship, as opposed to spouting off all your knowledge. Oh, well, this is this and this is that and this is this and this is that. And they don't have any chance to really
Yeah.
buy into anything. You're just spouting off all your knowledge, right? And
Well, and I try not to I try not to intimidate them by saying, I'm not like rapid fire questioning, like we're at a debate team just to see how smart you are. I'm trying to make sure you have this concept. And if you do, I'm done with these questions. We'll move on. If you don't, then I'm trying to narrow it down to where did I lose you?
Yeah.
You know, is it hemodynamics? Maybe you don't understand Bernoulli's principle. Maybe I need to kind of, because I teach them too. So I know what I taught you in class. So where did I lose you? So
Right.
that's the benefit of me seeing them, is because I already know what you learned.
Right.
Versus I had a sonographer ask a first semester student, tell me everything the liver does. She didn't know, you know?
Yeah.
I mean, and I honestly, I'd have to think about it if you ask me everything the liver does. That's a big question.
Yeah.
So
Yeah, that is.
can you make it into small parts?
Yeah. Right.
Narrow that down?
Right. So, do you have any other takeaways for building the student instructor relationship at all?
I do. I mean, just try to get to know them. Some people, just like coworkers, will tell you everything about themselves and they're an open book. And some are a little bit more reserved, but you can at least ask them, kind of a friendly question is, why did you pick ultrasound? What enticed you? Because we're a pretty unique field. Like, why did you pick ultrasound? Is it because, one of my students had a liver transplant. And so that's how she got into, most people, it's like, oh, I like babies. We hear that all the time. But I actually had a student that had a liver transplant. So she had a very interesting history as to how she came about, and learning about ultrasound. So that kind of opens you up to, oh, wow, you had a liver transplant at 20? I don't want to ask you what happened, but what happened?
Yeah. Right. Yeah.
So yeah. So I learned just as much from students, like, measuring the gallbladder now. We measure it in sagittal, and they teach me things all the time.
Right.
So
Right. I also think you made a point here that says create a safe environment for learning. And so I'd like to kind of talk about that a little bit because I think I have also experienced um, people training and maybe they go to a different trainer and the trainer's like, well, where are we at today? Where are you going? And where should I work with X, Y, and Z person on today? And instead of saying in front of the person that is being trained what their strengths are and where they need to work or concentrate, they're
mhm.
like, well, why don't you go for a walk with me down to the cafeteria? It doesn't really provide a safe environment, right? You're going to be talked about behind your back, and that doesn't ensue trust,
No,
right? So I think part of the thing is just to be upfront and honest with the person you're training. If you have concerns or um, areas that you want them to improve on, to be able to say what they're doing well and what you'd like to see them improve on as you hand them off to the next trainer is, I think, vital, right? There's no talking
exactly.
behind the back. And I think if you're training someone and you do have some really serious concerns, to take it upline to the manager or the director or someone of that nature, as
Exactly.
opposed to, well, let's go to the cafeteria and I'll tell you how she's doing. That's a little shady. And that doesn't really create a safe environment.
No.
Someone knows that they're being talked about behind their back.
Yeah.
That's not cool.
No, and like we talked about, not every sonographer has been given the toolkit on how to teach a student. They just know that they know how to do ultrasound. Not every evaluator has been given the toolkit on how to evaluate people. They
Right.
just they kind of revert back to high school. Well, I don't like her because of whatever.
Right.
And so I kind of go over, for new clinical instructors, or like you're talking about a training mentor, they really need to be trained the difference between subjective and objective evaluation. So, like subjective, I had somebody say, a student was, she was cranky today. I don't know what you want me to do with that. I need an example of how she was cranky today. Was she didn't go over the explanation of the exam with the patient? Did she not sit and talk with the radiologist afterwards? I need an example. That's being subjective. I have no idea. Ultrasound subjective. So I
Right.
need a measurable goal. So if they say, well, I don't think she's getting it, that's great. What made you think that? Did she miss a couple of key images on the protocol? Did she not know a couple of questions the radiologist asked? What I need you to narrow that down, because otherwise that's your opinion.
Right.
So I need you to give me 3 or 5 facts of what you think she needs or he needs to improve on. And then I can work with that. Just telling me you don't think they're getting it isn't helping me, and it's not helping the student. So give me a measurable land goal or landmark to get to, and then we can get there. Otherwise, you keep moving the goalpost, and I'm never going to get her there.
Right.
Yeah.
Right.
So
I think you brought up an excellent point is to be specific, right, with your feedback. So I know some of the feedback I've gotten sometimes or I've seen being given is like,
mhm.
that's interesting. You know, some people don't like dual imaging. And at certain places, they ask that you put like extremities on a dual image because they can remember it better. Like, okay, I saw this, I saw that. I know she's going to do this, and then she's going to do that. And so for physicians, sometimes it's helpful. But some physicians don't like dual image, you know? And so on a dual image, I saw someone give some feedback. They're like, you're not getting all the anatomy here. You're leaving out a lot of anatomy. And I saw the person just like nod her head, like, oh, okay, you know. And when
Mhm.
I looked at the image, because I was kind of curious, I'm like, the anatomy's there. She just didn't want her to do dual image, right?
Yeah,
And
so just be specific and say we really don't care for that here. Okay.
right, right. So it's important for the instructors to be able to be specific, right? And call out what they really want. You know, I think a lot of people are afraid to say what they really want, right?
Yeah.
Say we don't like dual image as opposed to you're not getting the full anatomy here.
Yeah.
You
And that
know,
is the difficult thing about sonography compared to other modalities because, I did X-ray and CT. An abdomen protocol on CT is pretty much the same, a hundred different facilities.
right,
And,
right,
and on sonography, it depends. If I go to this hospital, this radiologist wants it this way. And if I go to this hospital, maybe a hepatologist wants it this way because the
right,
patient's got cirrhosis and he's looking for this. 100 different, same thing with OB. Some MFMs want this and some want a different protocol for fetal echo. It's very subjective. So I need you to be like cookbook specific on
right.
what you want.
Yeah, and
I can
sometimes
do it,
that's
but you
hard
need to
for the
tell me,
trainer, right?
yeah,
Sometimes that's hard for the trainer. So
yeah,
as a trainer, you need to be able to sit back and evaluate, okay, what do I really want on this image? You
right.
know, oh, I want I want to be able to see the pulmonary veins going into that left atrium. I need to see it connect, right? That's different than feedback of you want to rule out total pulmonary venous malformation, right? Like those are two totally different things that you're looking for, right? So
Yeah,
to give both of those pieces of feedback to somebody would be kind of confusing, right? And
exactly.
so
And we
as
just had this conversation today in class, especially because I was teaching OB. Every picture I told them, well, it goes for every modality, but teaching OB today, every picture we take, you're telling the doctor something on that BPD. You're telling him not just the measurements, you're telling him, do you see a cavum septum pellucidum? If you don't, what does that indicate? Did I see the cerebellum? If I didn't see it well, what could that indicate? If the cisterna magna is large, what did that indicate? If I don't see the fetal stomach, like we actually had a patient today in lab, she was so kind. She had her baby has trisomy 18. And she said, and we take OB volunteers. And she said, I'm being followed by an MFM, but I would, if your students don't mind, I would love to come to the lab because we know our time with her is limited and we just would love to see her as many opportunities. And I'm like, bring it. My students would love to see your baby,
yeah,
and it
yeah,
was such a wonderful learning experience. But I'm like, see, now we can't really see the stomach very well. The baby had esophageal atresia. She's got polyhydramnios, but it helps cement those pictures together. Every picture is for a reason. And we take it in a certain order. And every doctor wants something different. But I need you to understand why, you know.
right.
And the more specific you can be with whether you're training a new employee or a student, the better their outcome's going to be, you know.
Yeah,
When I
yeah,
was a teenager, I didn't want people to tell me what to do. Now I want you to tell me in chronological order every day
right,
what you want me to do. So I get it right for you 100 times.
right, right.
So, yeah.
So
But
tell me about this Bloom's taxonomy uh,
so
strategy that
oh,
you
so
that
Bloom's
works.
taxonomy is kind of a pyramid of learning. So the higher you go on the pyramid, the higher your critical thinking skills, and the lower you are is kind of the base level. So the base level, so if I have a student and I only have like 2 to 5 minutes to spend with the student, this is especially good for people that are at the hospital, not so much an instructor, but if I'm a sonographer working with a student, if I've got 2 to 5 minutes with you today, what can I teach you in 2 to 5 minutes? So you can do the bottom levels of Bloom's taxonomy, which is like recall and all of those levels. I can ask you a basic fact question, a protocol question, just a one word answer like, this patient has an elevated white blood count. What does that mean? Okay, they have an infection somewhere, but something basic and something quick. If I have like anywhere from 5 to 7 minutes, then I'm going to ask you a higher level question. This patient, they suspect they have cirrhosis. What else is associated with cirrhosis? Like portal hypertension. What happens with portal hypertension? What's a treatment for that? So then I can ask higher level questions. It depends on how much time I have with the student as to where I'm going to ask the questions on that Bloom's taxonomy. And also if they're a first semester student, or they're a senior student about to graduate, you should be able to walk me through the whole thought process on, pancreatitis.
Right.
So that's kind of how we use Bloom's taxonomy. And again, that's something that I didn't learn how to teach until I went to grad school. So these are tools that a lot of people don't have that are easy to use, and they help the student, and it makes your life easier. Then you're like, I don't know what to ask the student. Okay, well, here's a little cheat sheet of some questions that you can ask. A protocol question, a lab question that takes 2 to 5 minutes for them to figure it out.
Right.
So,
Right.
and I can do that while we're walking up to do a portable together. This patient has a history of this and this that we're doing a portable on. They saw this on a CT. Why do you think they ordered an ultrasound? What do you think they're looking for today? Might be nothing, but what do you think they ordered it for?
Right. Right. Yeah, that's important to know, right? Going in ahead of time. That's an important part of the ultrasound learning. What is the point strategy that you like to, I think we've kind of touched on it a little bit, but tell me more about the point strategy.
So I kind of have like a little grading rubric on, okay, is my screen like really blurry, or is it me?
No, I
Sorry.
don't think it's blurry.
Okay. My our lights just dimmed. I'm like, can you even see me? Okay. So the point strategy is kind of it's like a grading rubric. So we kind of have it the students have it in their clinical notebook that they take with them. So if the clinical instructors want to know, like, how do we grade them? Like, how do I assign points? Do I assign points for comps, like so many points for the protocol questions or the lab questions or pathology questions? So we just kind of assign, it kind of gives them a baseline as to how to grade them. Because if you haven't had a student, or if you hadn't had to train an employee, like we talked about, not everybody knows, what should I grade them on? What criteria are they looking for to get better? So you kind of have to give them, a structure as to where to start. So, and then we kind of give them a little cheat sheet on, what we're looking for. And
Awesome.
if it's below a certain number, then if you're at a clinical side, I need you to reach out to me, because that's my job. You're busy, you're with patients, but if you're thinking they're not getting it, then that's my job to intervene and figure out where they lost. How do I get them up to speed? My job is to build their success. So you tell me where you see there's a problem, and then I intervene and try to get them up to speed again.
Awesome. Yeah, I think the point system is good. And I don't think that's really used a whole lot when maybe mentoring or training someone on the job, but it's certainly a good way in an educational clinical setting to be able to evaluate, right? Like, what are my parameters for being able to evaluate that?
Well, you have to be able to measure success, because, when you take a final exam in school, I mean, did you pass it or did you barely pass it? I don't know. Did I
Right.
make 100 or did I make a 70? So same thing with the student evaluation. If I don't know where their points are at, I don't know if they barely scraped by or if they've got this, they're good. So
Right.
that's kind of, the points are not really to penalize them. They're to help me understand if there's a knowledge gap, how do I fix that?
Yeah.
So, and
Awesome.
same thing with training somebody. If they're not, if you're saying, well, I don't think you're getting it. Okay. On a scale of 1 to 100, am I a 70 or am I a 98?
Right.
Because I
Right.
want to know where am I now, so that I can figure out how to get up here.
Right. Right. And I think that's crucial to training anyone, right? Because you need a starting point, you need an ending point. And
Mhm.
people like to be able to know, okay, where am I at in that, right? So I think that's vital to any kind of training, right? You have to be able to measure your success.
Well, even if you're just, training somebody on how to change the oil in a car and be a mechanic, there's got to be a standard of protocols of what to do and how to know if they're doing it correctly and how am I measuring that goal for any task. So there
Right.
has to be some type of points or something. Otherwise, it's too subjective. You're like, well, you're not doing a good job. Okay, but can you quantify that? Because if you can't, I don't know how to get there.
Right. Exactly.
And we all want to be better at our jobs, no matter what our job is. We just have
Right.
to figure out where we need to improve.
Yeah. So in closing, what would be some points that you would give to someone who's instructing, teaching, mentoring?
I would kind of tell them to try to figure out some micro lessons. You can Google micro lessons or chat GPT, micro lessons for ultrasound, micro lessons for OB ultrasound, and it'll pop up like some key facts to ask students, you know. If you don't know, you can ask their instructor like myself, and I'll email you a list of questions of what they should know, where they're at right now. But at the very basic, start off the day with, I'm Brandi, I'm your sonographer that's going to be working with you today. What are you working on? What comps do you want to get today? What, if we have time, what do you hope to scan today? What's your favorite thing to scan? What's your least favorite thing to scan? Basic things like that. If you don't want to ask them about Bloom's taxonomy or Bernoulli's law, that's fine. Why did you pick ultrasound?
Right. Right.
Get to know
Right.
them. We're all, it's a unique career. So find out why they chose it.
Yeah. And I think it's important too. I think you make note here of that it doesn't have to be perfect to be powerful, right? And I think the other thing I think of is that you're enough. Like, how many of us think, oh man, am I enough? Do I know enough to teach somebody? Am I qualified? Like, so I think sometimes even you have to train people who have more years experience than you. And so maybe you feel insecure, but you have to know you're enough for that person, right? That
Well,
you know something that person doesn't know. And you're enough to show them the ropes and do the things to get where they need to go. And just to keep the end in mind, right? To keep the end in mind. We're here to get you competent.
and not only that, not just thinking like you said, are you enough? If I always think, what am I going to learn from this? If I have a student, and I've been doing this, I've been teaching for 16 years, I've been doing ultrasound for 32. I'm always learning something new. I thought I knew all kinds of things about doing OB after doing OB and MFM. Well, then when you have to teach it, and I have to learn all these things about the Bain of Gallon and all the things, that makes me a better sonographer. You
Right.
know, so I tell them all the time, I'm humbled all the time. I learn things all the time from you guys, from the clinical sites. When I do international medical admission trips, they teach me
Right.
things I'm never done learning. And that's why I love ultrasound.
Yeah.
You're
Yeah.
never done learning.
Yeah,
There's so many cool things for our job.
absolutely. The one thing I want to leave with sometimes is I think of this little video that I saw, and it was of a businessman, and he calls up one of his workers for employees,
Mhm.
and he says, "Come on, let's walk across this room." And he just kind of puts his hand on his back gently, and they walk across the room. And he goes, "Okay, let's just take like 3.5 steps back to the middle." And he said, okay, so they take 3.5 steps back to the middle together, right? And then the owner walks away. It's kind of thinking a little bit. Then he comes over to the man and he says, put your hands up. And he puts his hands against his hands and then he starts pushing. And immediately the guy was resisting him, right? Because if he didn't resist him, he'd fall over,
Right.
right? And so the employee sat down and he says, you know what? When I walked with him, there was no resistance. He didn't know where I was taking him. He didn't know why I was going that way. Nothing. When we did this together, no resistance, none at all, you know? But as soon as I came and I started resisting him, he started pushing back and resisting me. As
Oh,
soon
okay.
as I started pushing on him, and he didn't know I was pushing on him, but I was pushing on him hard and he was really strong. He immediately started pushing back. Right. And I thought that was a powerful picture to mentors, trainers, clinical training trainers that if you feel resistance with someone, step back a little bit and see why do they feel resistance?
Right.
why am I feeling resistance with this person, right? Am I pushing too much, too hard, expecting too much? Am I not pushing enough? Um, I think there's always a reason, but if they feel like we're doing this together, then I think the resistance goes away sometimes. And I'm not saying it's perfect for everybody, right?
I know.
We're all different people. We all have all different personalities. It's not going to work with everybody. But for the most part, if people feel like we're doing this together, you get very little resistance, right? As opposed to pushing on them and pushing on them and pushing on
Definitely.
them.
If you have a good employee and they feel valued and they feel appreciated, they're going to work 10 times harder than if they, didn't feel valued. They just felt like they were just taken advantage of. So a kind word and being encouraging, I really appreciate all the help you gave me today, goes a long way. We're all overworked
Yeah,
and
I think sometimes the pushing comes from our language, right? Or the defensiveness comes from our language. So I thought of this the other day in marriage counseling. I don't know if you've ever been, but they talk to you about not using you statements, using I statements, right? Like not saying you did this wrong, this isn't right, this isn't right, this isn't right, saying we might do this a little bit differently, or here the doctors prefer blah, blah, blah. Using that kind of language is so much less defensive or reactionary with people
exactly.
than using, well, I wouldn't have done that, you know.
Right. Yeah, it's
Um,
on the approach. Teaching is a lot like leadership. Not everybody, and we've all had good bosses and bad bosses.
right,
Not every boss is taught to be a good leader, and not every educator or preceptor was taught and has the skill set to teach. So the
right,
more that we increase their skill set and their little toolbox on how to teach students or how to manage or how to be a good leader, the better we're all going to be. I appreciate having a good leader that I can learn from. You
right,
know, whether it's my boss or an educator.
right. So in closing, just, watch your language, right? And know that you're powerful, you're enough, and what they're not going to learn everything they need to know just from one person. I
No.
think it takes a multitude of people, a multitude of experiences for them to learn, for us to learn.
Yeah,
So,
and I also encourage sonographers to be humble. Tell them, I remember when I was a student, this was what was overwhelming for me. For me, it was physics. I am not a math girly. I love science, but physics was not my strong suit, and I struggled and struggled to get that freaking SPI done.
right,
So, and if I tell the students, I see that you're struggling with physics, that doesn't mean you're going to be a bad sonographer. I struggled with it too, and I'm a good sonographer.
right.
So we all have something that we struggle with. So humble yourself and remind them, I was a student. I remember,
Yeah.
it's hard. You'll get it.
Right. And you're not alone. I think that is what, you're not alone. This is normal to feel this way, right? I felt this way too. Many people feel this way coming through. You'll make it, right?
Yeah.
Giving them hope. So,
And like you said, keep in mind that we all have challenges at home or our personal life that hopefully you're not bringing with you to clinical, but it does affect how you perform at clinical. Maybe you're not on your A game today, be
right.
humble.
Yeah. Yeah. This was wonderful. I really appreciate this. I think this
Good.
was a lot of information for a lot of people, and hopefully we can just step up our game a millimeter at a time, right? It's all
So,
about the millimeter and getting better. What do they say? 1% better every day. Um, so thank you for sharing again your expertise and experience.
I
And
felt like I was a
I,
ping pong ball all over the place, though.
you what?
I felt like I was a ping pong ball all over the place today.
Oh, I think you were great.
Okay.
I think it went just the way it needed to go.
Okay.
So thank you
Perfect.
so much
No problem.
for your
Hey,
contribution to ultrasound.
oh, thank you. Well, it was nice to speak with you again. I always learn something when I talk to you too.
Thank you. Thank you for tuning in to It's All About the Frequency podcast. I hope you enjoyed today's episode. Share it with a friend and remember to keep your frequency high.